founder of Advanced Artificial Eye Services from India. Today I will be discuss about the history of ocularisti and ocular prosthesis management and case of ultra thin shell. First, history of ocular prosthesis. Uh,
Mr. Ray,
prosthetic eye. Yes, ma'am.
can we please make it full screen?
Mm, Is it okay, ma'am?
Yes, that's perfect. Continue,
Okay.
Mr. Ray.
History of ocular prosthetic. Prosthetic eyes have a history that stretches back to at least 2900 BC. Prosthetic eye material and techniques have evolved in keeping with the times from clay to wood and ivory to enameled silver and gold to glass and finally to polymethyl methacrylate. This is a plastic material. This last step was accompanied by a change in the profession that supplied and fitted prosthetic eyes. PMMA eyes could be custom made, but this required a different skill set to the one that ocularists had used successfully with glass for the previous 500 years. The technologically and professionally dislocation that the change from glass eyes to PMMA brought about 70 years ago. What is the anophthalma? Yeah, anophthalmia. Anophthalmia, the absence of one or both eyes, may be congenital or it may be due to trauma, eye disease, requiring the surgical removal of the eye. Disfigurement of the eye may also result from other congenital defects, trauma or eye disease, and in this case may be appropriate to use an ocular prosthesis to the disfigurement. Sometimes it will be more appropriate to remove the disfigured eye. And understanding of the surgical process employed is important for those dealing with this patient. Anophthalmia and microphthalmia for young children and to choose enucleation, evisceration and exentation procedure for the surgical removal of the eye. The different types of intraorbital implants commonly inserted into the orbit during enucleation and evisceration procedure are discussed, as well as changes to the anophthalmia socket that typically take place over the longer terms following eye removal surgery. This is a congenital microphthalmia. Microphthalmia means babies or adults with small eye are born with the one or both eyes, small and underdeveloped. Some children may become blind, but others may have some residual vision or light perception. Microphthalmia occurs in about 1 in 10,000. This condition range from simply microphthalmia, where the anatomically intact except for its short total axial length, to severe microphthalmia, where the globe is severely reduced in size, around 10 mm at birth, less than 12 mm after 1 year, and with a corneal depth of 1 mm diameter less than 4 mm. What is the basically we will doing our treatment in anophthalmia and congenital anophthalmia for children with severe microphthalmia or micro usually to stimulate hard and soft tissues growth of the orbit to reduce any asymmetry of the face as such as possible the child grow into adulthood. The growth of the eye mostly occurs during the first 3 years of life. The microphthalmia eye grow by a variable amount during this time depending upon the severity of the condition. It is important therefore to start treatment as soon as practically after birth within a first month if possible. The main treatment method is to support the eyelids in their natural position. The presence of conformer stimulate orbital and axonal growth and a series of conformer increasing the size are fitted over the course of the 1 year so that normal size and relationship can be maintained. Initially, conformer needs to be replaced weekly, then monthly, then quarterly at that longer interval until the socket is finally ready for a more permanent ocular. And what is the thicycle? Thicycle eye, the nature of the disfigurement in considered the commonest appearance of and stage blind eye, particularly after severe ocular disease, trauma, exposure to radiation, eye infection, or inflammation in thicycle vulvi. This is where the entire globe shrunken. Once thicycle vulvi start, it is often progressive and is usually associated with shrinkage of the cornea. So measurement of the remaining corneal diameter, normally 10 to 12 mm, is useful gauge of the degree of phthisis. Mild degrees of phthisis can be managed with a prosthetic contact lens or a ultra-thin scleral shell ocular prosthesis. And that is a contacted socket. Contacted socket, one of the most dreaded complication of the anophthalmia, referred to shrinkage of orbital tissues accompanied by a reduction in the orbital volume along with a decrease in the fonical depth, where the contacted socket is divided into 5 grades. First, salving or shallow of the lower lid, lower fornix. Second grade is loss of the superior fornix along with the inferior fornix. Grade 3, involvement of all four fornix, superior, inferior, lateral and medial. Grade 4, involvement of all fornix along with a reduction with the horizontal palpebral fissure length. And we will discuss about case presentation. This is a ultra thin shell based on case. It is a case of 35 years old male. He was diagnosed thicycle bulbi in left eye. The vision in this eye was PL negative. He was looking for cosmetic betterment, but a conventionally prosthesis could not be fitted in his eye due to less volume loss. He was referred for evisceration before fitting of ocular prosthesis. Patient was not convinced for surgery and wanted to try prosthetic contact lens, but due to corneal flattening, contact lens was not retaining in the center. He was referred to us for a trial of thin scleral shell. Clinical evaluation: on examination of his fellow eye, the eye was within normal limit and best corrected vision was 6's. Affected eye: on examination there was mild retraction of the upper lid and lower lid and socket were normal. In physical eye, corneal sensation was minimal and there was no ciliary tenderness. After examination, we decide to try making of thin scleral shell. The, we start the process begin with the impression of socket. A large but thin impression tray was selected for impression. Impression was taken by the alginate material. This impression was casted in the plaster and a thin clear acrylic shell was prepared from the impression. This clear shell was tried in patient's eye. Once the shell was settled in the socket, patient was asked to wait for 1 hour to check the adaptability of the shell. In this patient was very comfortable. We asked him to look in all directions to check the comfortable level. Once patient was comfortable, we plan to convert this shell into the final painted scleral shell, a final painted ultra thin shell. Acrylic shell we process first a circle with the help of marker pen was marked over the clear shell to find the location of iris. Once the placement was fine, then a small piece of Q-tips was attached with the help of wax to check the right tilted of the corneal gauge. With the help of the shell, a new mold was prepared and use a curved solid black corneal button was selected and its diameter was reduced to the desired dimension. The button was placed into the mold and a white acrylic was prepared. Then this white shell was polished properly and again tried in the patient eye. Once we were satisfied with the dimension, we checked the thickness of the shell before trimming. If further of painting, on a scale it was 0.65 mm thin in the center. Very carefully this shell was trimmed further for scleral painting. And that is a corneal thickness 0.65 mm. Scleral painting was done. Then, 1 hour later, the patient was presented with a clear shell. Patient was asked to wait for 1 hour to check the adaptability of the shell. Once the patient was comfortable, we plan to convert this shell into the final painted scleral shell, a final painted ultra thin shell. The shell was laminated by the clear acrylic after multiple stages polishing, and the final shell was tried in the patient eye. Once patient was comfortable and satisfied, the final shell was dispensed to the patient. We will need uh, for polishing to check the main point like sharp edges, pits, dye stone material in artificial eye, red threads, exposure should not be there, sketches mark, and polishing with shining. This was the final result of the patient, and conclusion: with extra efforts and a carefully fabrication, a ultra thin shell can be prepared, and we can avoid the surgery just only for volume loss in such cases. Thank you. Thank you, everyone.
Thank you for this beautiful presentation, Mr. Aman. It was really, really يعني full of information new to most of the ophthalmologists of how to make a prosthetic. It is very useful for us to consider these parameters in our choosing patient or choosing the right option for this patient, and the choice will be fitting to him. Any question from the doctors? Any question from any doctors? Please raise your hand to and unmute yourself. Okay. So
I
we
hope
thank. Yes.
I hope everyone is very satisfied with this presentation. So thank you everyone for listening this presentation, and thank you so much for uh, giving this opportunity.
You are always welcome, Mr. Aman, for your precious contribution in our community. Hoping that this won't be the last presentation to give us in the next time. Dr. May, are you going to ask?
Thank you so much.
Dr. May Alwan,
Yeah.
are you going to ask, Dr. May? You are muted yourself.
Oh, I'm going.
No, thanks. By mistake, Dr. Khulud. Thanks. Thanks, doctor.
Thank you.
So we thank Mr. Aman Agrawal, clinical ocularist, fellow of Silver Line Laboratories, fellowship from Art Eyes and Pan America Ocularists and Contact Lens Association. Thank you very much, and I hope you to join us and to give more precious contribution like this presentation in our community, Ramadan. Thank you so much, and thank you for all the doctors are listening with us today.
Thank you, ma'am. Thank you so much.
Thank
Yeah.
you, and goodbye.
Goodbye, ma'am. Thank you.